Good morning, good afternoon, wherever you are. I'd like to welcome you to our webinar today, From Connectivity to Clinical Impact, Advancing Data Utility in the 2025 Digital Health Most Wired Era. This was a big year for our Digital Health Most Wired survey. We got more responses than we've had in the past. We also got awarded, a shameless plug for CHIME, the most impactful maturity model that is in the market right now. So we're proud of the work we're doing, and we're also proud that we have InterSystems as such a great sponsor to support us on that effort and to talk to us today about some of the key findings there. What I'd like to do, again, my name is Frank Catita. I'm Vice President of Digital Health Insights at CHIME. It's our content group. I'd like to take a moment to introduce our panelists and have each of them do a brief introduction of themselves, a day in the life of, if you will, and then we'll move right into the Q&A. So without further ado, Greg, you want to start it off?
Sure. Hi, I'm Greg James. I'm a senior advisor for public sector here at InterSystems, which means I serve as sort of a subject matter expert for the team on different programs and operations in public sector organizations, state and local government, community organizations. My background, I spent 8 years prior to joining InterSystems as Deputy Secretary at the Maryland Department of Human Services, where I also chaired an interdepartmental data governance council for about 6 of those years. So thank you. Look forward to today's discussion.
Kim, thanks for joining us.
Hi, I'm Kim Humby. Thanks for kicking us off, Frank and Greg. So I work in InterSystems as part of the product management team for our HealthShare platform. I'm a senior manager for commercial strategy, but I have about 25 years experience in interoperability, including I was just having a little nostalgia to the first Fire Connect-a-thon I went to back in, 2012, 2013. I don't remember the years at this point. But in general, I've spent most of my career at the intersection of delivering value for customers through technology, including about 5 years at a large health system doing emerging tech innovation. So I'm excited for the conversation today and debating a few of these interesting topics with Tim and Greg along the way.
We like the debates. We like debates. Tim, last but not least. Tim, you there?
Tim, you're on mute.
Tim gets the first stamp on the bingo card of forgetting to unmute. Thanks. You took one for the team.
Yeah. Okay. So that just I'm the doctor in the group and not a tech guy, and I just proved that. I just needed to make that point. So I'm a physician. I spent 30 years at Mass General. Was the chief medical officer and the CEO of the physicians organization there. But my academic background is in economics, health economics, and policy. And recently I was the National Director of Transformation for the NHS and got to live in London for 3 years and was responsible for all data and technology in the NHS. And then most recently have been working with startups in the US, AI startups in healthcare. And then exactly 1 month ago, started in my current role as VP of Healthcare at InterSystems.
Congratulations. Great panel, great diversity too. Always like the doctor's point of view. Just want to move right into the questions considering the time that we have. I don't know if everyone's familiar with the, at least in my age group, the old song by Simon and Garfunkel called The Boxer.
Oh, yeah.
You remember, and I've always used the boxer as sort of an example of one of the lyrics that they have that's related to healthcare data. It's man hears what he wants to hear, but disregards the rest. So that sort of leads into our first question. Our research shows that 45% of organizations still don't trust their own data. And even if it's technically available and flowing and democratized, what does the journey from raw connectivity to trusted, actionable data actually look like in practice? And what was the turning point that shifted your organization's or your customers' confidence in this data? So what was the boxer eliminator there that said we trust it? So Tim, I think why we'll start out with you, considering your role and the other side of it.
I love that line. I actually use that line a lot.
That's good.
There's so many instances when that is the appropriate thing to say, because actually it really deeply connects, because what is essentially being said is that we have strong biases in the way we intake information, and those biases can be obviously at the personal level, but also at the institutional level. And so your survey, Frank, and the disconnect that you're pointing out between, okay, the data is flowing, but we still don't trust it, has multiple layers to it in my in the way I see things. The first is that trust for what purpose is actually something that you can dissect. And so we use, I really like what's called the all and just framework for information. So military sit rep thing, which is you want all the information you need to make a decision, but just the information you need to make a decision. The problem is that is a theoretical aspiration, but very practically difficult to deliver in every circumstance. And so for clinicians making a decision, there are at least 4 implications of every decision they make. There's the person, the health of the person in front of them. There's efficiency, operational efficiency. There's cost, and there's population health. And so the information, are you trusting the information for all of those separately or differently? It's going down a little bit of a rabbit hole. But then let me just say that the clinicians who are using information are used to approaching all information with a certain degree of skepticism. Let's say my patients have very different descriptions of their chest pain. And so I have to listen for potentially what that information might mean. The same is true when we're confronted with sort of information from our organization, or I'm always looking like, does that make sense in the context? And if it doesn't make sense, I might be downweighting it, or looking to, for example, repeat a test. And so I think, Frank, that's it's when you look under the cover at what trust means, there's several different layers to that. And I would love to practice in a world, I've always practiced in a world where I had limited information and limited trust in the information that I was receiving. But I do think it's getting better. I've seen it getting better, and I'll give you one example of a very specific UI UX that helps, and that is provenance tagging. So when you get a fact, if the provenance of that fact is tagged so that you know where that fact came from, be it an outside hospital, be it internal, wherever, but being able to trace the provenance of a particular fact that you're using to make an assessment is a big enhancement in building trust. And that is a UI UX build that is moving us in the right direction.
So trust is the source in essence, right?
Yes.
Okay, which in a world of cognitive overload, on top of all this, it's not a matter of not having enough information. The other part of it is having too much information to make a legitimate choice and decision. Greg or Kim, anything to add to that?
I just want to add one little point, and I think everything Tim said is completely right. You need to build up that trust in the data. Having the provenance of the data is critical to that. I also think there's some foundational pieces that every health system or payer organization or whatever type of organization you are needs to get right, and that's at the core. The patient identity is foundational. Then understanding the data structures and having your harmonization of the data, then you can get to all of the other elements like provenance and trust and all that. But if you don't get some of those foundational pieces right, you're not able to move to the more advanced level stuff. I remember when we first started rolling out HIEs, we had a platform that we started in InterSystems in I think 2006, 2007, and it was the foundation of some of the larger HIEs around the country. And initially, we were doing a great job of bringing and aggregating all the data. And then suddenly, to Tim's UX point, people said, oh, well, I don't just want to see the deduplicated allergies. Thanks for deduplicating them. But I also want to know which health system put each of these allergies in, or which provider org this came from, or which department this came from. And so we had to then start, luckily we had the provenance in the data model, but we had to then start adding this in that we thought originally would have been noise to the clinician, but it upped their trust, even seeing, identify which organization that data came from. So I think that was a really great point.
That's great. I like that. Greg, anything else? Covered?
No, I mean, I think they nailed it. And I mean, I could throw in another example. I mean, when I first started in discussion with one of our other clinicians who works at InterSystems, it pointed out, even something as simple as a lab result that you would think, well, this number is going to be the same no matter what it is. Knowing which lab produced that result also tells you, well, this lab we know uses this test, and that test has this degree of variance or not. And all of that goes down to trust. I think the other thing is, when they see this data, having the provenance is important, but every time you see data that is wrong or that doesn't make sense, lowers your trust and lowers your confidence. And that's why, as Kim was pointing out, having that basic functionality in the applications that can handle things like deduplication, handle things like standardization and harmonization, and making sure that before we start putting that information in front of the end user and the clinician, we've ensured that it is the right type of data in the fields, so that it's usable and reliable and trustworthy just looking at it at the screen, as opposed to, well, I need to stop and really think, I can't trust this, so I can't incorporate it into any of my automated processes. I need to stop it all at the front door and manually troll through it before I can decide to start using it.
So this leads nicely into the next point. I mean, the governance and action part, and closing the policy to workflow gap. I mean, it used to be that you call in sick if you had a governance meeting coming up next week, but now governance is cool. I'm like, oh my God, I can't afford to miss this artificial intelligence or combination of artificial intelligence and cybersecurity. I mean, people really wanting to go to governance meetings when it was, I'm sorry, I think my kid's going to be sick that day. But the same point, the data shows that 39% of the organizations we survey have formally chartered governance functions, yet 45% still don't trust, first of all, what we just talked about. They don't trust their data. And many, even worse, struggle to translate that governance decision into EHR workflows and operational practice. So what specific mechanisms have you found that actually close the gap? Not just what the governance committee decides, but what materially changes at the point of care. Where does governance meet the people, I guess, is the question I'm asking. Greg, I will let you start with that one.
Sure. So I think for a long time, folks have always looked at when you say data governance, what jumps to mind for people is, oh, well, that's compliance. That's making sure that we have cybersecurity. That's making sure, saying who can access the data and who can't. And that is all certainly a really important part of it. But it also sort of shoves it over and says, this is an IT and a technology problem. IT, you deal with it. And the problem with that is data governance is really also about making sure that your data is meeting your quality standards. And that you understand what this data is and what it's going to be used for and how it's going to be incorporated into the workflow downstream, so that your IT team can build the systems that reflect that. And you can't do that unless you have those end users involved and engaged, and not just in one round of sitting at the table and saying, okay, what should the standard be? What should the policy be? But giving that continual feedback and saying, this is what I'm seeing as an end user about the data that's flowing through the system. This is what we need to change in our policy, or let's set a threshold for what is acceptable for data that we're getting from these external sources. So whether, now with TEFCA and all of the HIE networks and the national networks that folks can access, you've got all of this data coming in. You need to be able to determine as an organization, what are those filters going to be? What are our standards and thresholds going to be for whether data is usable, whether it's not, how we're going to interpret some of this data coming in. And, even the best subject matter experts on the IT side are not a replacement for the end users, for the clinicians and the physicians who understand this is how I'm using this data. So, and by the way, you've designed a system to do X with the data, but I need to be able to generate a report at the end of this. And now I can't do that because you're storing the data in the wrong way. So that data governance really needs to be a partnership between both the business users and the IT teams, who are then going to implement those standards and those thresholds. And that's the other side, is you really do want to make sure that your technology platform, as your business users start setting those standards, your technology platform has the ability to implement them, so that you're not requiring a lot of manual intervention to get your data to the point where it's useful.
Interesting. I want to get Dr. Tim in here just to see where do you feel the most common breakdown is going from IT to the proletariat, let's call it. And is it people, culture, workflow? I mean, or a combination of all? But you see it through a different lens on the clinical side, or have, and still do, I'm sure.
Well, I think Greg's description of, and your description, frankly, of the progression from not that interesting, very tech focused, to actually it's really critical, goes along with, suddenly it's not individuals who are just the consumers, and we rely on each individual to make choices about what they trust and what they don't trust. And frankly, the liability is on them. And that's what I said originally, is like we are trained to be skeptical of all information.
Do no harm.
Do no harm. But now data governance is really about the fact that as we move to inference engines and LLMs giving advice, summarizing documents, giving advice, giving clinical advice, any systematic biases in the source data will result in systematic inaccuracies and biases in the inferences. And so that's not one individual mistakenly using one piece of data. That is a systemic problem. And so the bar for how good your data is has to go way up, because we are now at risk of running systematic problems because of the data, whereas before that was less likely to magnify the source, the impact of an error or inaccurate data. So now the stakes are higher, and also I just want to point out the benefits are also higher. So but the stakes both in positive and in negative are higher, and so suddenly making sure that data meets the all and just rule, meets the accuracy, does all the things that Kim pointed out, standardization, normalization, deduplication, all of that has got to be at a very high bar because of what we're about to do with it systematically.
Right. Interesting. Kim, a closing thought?
No, I think the guys summarized it really well.
And that's great. I do too. So inevitably, you lose your journalistic license if you don't mention fire at least or AI at least 5 or 10 times in a session like this. So I'm going to do it. So let's look at the what I guess we could call as sort of the fire maturity model from compliance to architecture. So our research shows there's just a wide spectrum of fire maturity. I think Kim mentioned when she was on one of the first fire sessions or conferences way back when. I mean, now we have it that people say, I think this is great because I have to satisfy the 21st Century Cures Act, and they put it in there. Some are using CDS hooks and fire subscriptions as a primary integration layer across the entire ecosystem. Where do most of your customers fit on that fire spectrum? I mean, where does it go from being something that's a checkoff box, like we got to do it, sort of like governance used to be, but now it's really important, to it's really truly fire native operations? How do we get to that point of checking off the box and actually making it part of the fabric, Kim?
So I'll go in the path that you did, Frank, and I'll reference a song from my youth, the infamous New Kids on the Block, Step by Step.
Okay.
So I think that really is, it sounds simple, but it is step by step. You can't get to the end game of the maturity model without really starting at the basic core interop level. As much as we would like to think that, this many years later, that every application within a large hospital system is speaking in fire, the truth is a large percentage still aren't. And so even if the health system is, doing work with fire, perhaps they have a fire repo or a fire server, and they're able to do API level interaction around fire, they're still doing the bulk of their backend interoperability in non-fire native applications, right?
Mm-hmm.
So I think from my perspective, getting and moving up the maturity model really comes down to, I would say, a core product management principle that I've, I'll show my product management background here, but why, right? So you always start with why. If you're trying to say, hey, I want to move up the maturity model, as much as maturity models do give you a great framework, you've really got to say, what are the outcomes we're trying to achieve with getting to stage 3? What is the application or the thing we're going to be able to do? What is the improvement to patient care? What is the, improvement to the working lives of clinicians and pajama time and all those concepts, right? What is it going to get us if we move up the maturity model? In my time outside of InterSystems, I have an interesting background in that I spent 17 years here, that I went to the real world and worked at a large health system in New York for 5 years in innovation space, and then came back to the vendor side, to InterSystems again, and came back home. But in that time, we actually, at the health system I was at, we were very advanced in terms of pushing the fire mandate, went through a lot of the hard work of really getting the data to be trusted, trying out different ways of using fire. And I was very privileged to be there during COVID, when we actually got to deliver a lot of true value coming out of having built that fire infrastructure. So that allowed us to do subscriptions and notifications for lab results and COVID test results and alerts almost within the first week of the COVID stuff kicking off. So I do see the value of you getting further up the maturity model, and you can actually achieve real things when you're able to use the data in this way. But the same foundational pieces come into play, right? You've got to get your data identity, your patient identity matching correct. You've got to get the provenance of the data correct. You've got to build all that foundational work, and then moving up the maturity model is easier. Across our customers, we see them from end to end on that spectrum. It actually worries me a little bit when people are concerned about moving up the ladder and saying, okay, we've got to be fire native, but haven't truly looked at what the operational and clinical value is of doing things in that way, right? Because then you end up with projects that really struggle to get to the end. So right now, across our hospital systems and customers, we have some that are doing the API level stuff and ready for more of a fire facade which is, you're leaving your data in its systems in its native form, and not trying to, push fire natively in there, but you're able to build a nice facade around that. And we do that with some of our products, to allow you to start to more naturally interact in the fire-based world, without having to, do like mass replacement. But we are seeing some of our hospitals that are now further up that chain. CDS hooks, I think, is one of the easier entrants to start to see value, right? But then we are starting to see a lot more on fire subscriptions, etc. And of course, with all the exchange work now, and a lot of the stuff coming out of CMS, we're seeing a lot more push in the implementation guides for either facilitated fire or like true fire workflow integration. In the payer provider space, obviously, you've got now a lot of push for e-prior auth being truly done via a fire back and forth and true workflow integration, and we're seeing a lot more push towards that because it's a true practical application for it, right? I'm also curious. I'll share the mic, but I'd love to pass to Tim, because I'm curious with your recent time, both obviously in large U.S. health systems, but also internationally at the NHS. Where were you seeing in terms of the friction here, and were people really starting to achieve value from using fire in this way?
Take it, Tim.
Well, it's not. You can tell I'm trying to choose my words carefully here. Let's just say that the NHS has historically underinvested in technology. And I actually wrote a paper in the New England Journal, published last January, about this. It details all the underinvestment. So I'm not saying anything out of school. It's well known. But since 2009, since the financial crisis, they had invested about 50% of average across OECD countries in their technical infrastructure. And so, Kim, the leading, the people who were showing the way were, doing really, really well, but that was a very small subset of relatively well-funded, usually academic centers in, London, Oxford, Cambridge, Manchester, the big cities. The vast majority, they weren't even in a position where it was an aspiration to talk about moving up into a fire-based application. So yeah, I don't know what else to say except
that was good. That was good.
It does give some perspective on everything's relative, right? So when we are kicking ourselves for not getting farther along on the journey, on this particular thing, if you look at other countries, we're actually in relatively good shape. I will say though that they have something that we don't, which is they have their national healthcare data spine. So they have a national healthcare flow of data that we simply don't have, and that which obviates the need for a lot of the stuff that we have to build. So, pros and cons.
Closing thought, Greg. I just wanted to bring up one point of my own. We do a lot of work on maturity models. I've been involved in them for years, but one could argue maybe that what's happening with AI, agentic AI, whatever you want to put in front of the word AI, is creating sort of an impromptu immaturity model. That we might be mature in this, but we're totally immature in terms of our AI implementation, when in fact so many of these things are based on AI, whether it be fire or other protocols. And we're sort of seeing that you know, I was really the big man on campus or person on campus before, but now this other thing is encroached, and now it's tough being as mature as we were at the pace of speed that this technology is working. So I'm just, that's not a question, just sort of a thought in watching how maturity models change into what we call immaturity models. And I do that with hospital at home. I said there's no real hospital at home maturity model. Right now it's mostly immaturity models. So I want to jump back over to Tefka, and you know, so many things going back to the, you know, we have these checkoff boxes. Tefka, okay, got it done. Where do you think the gaps are in institutionalizing something like that? Where are the gaps, and what's sort of holding people back, or you know, keeping them from just paying lip service to it and actually having it in action at many different levels in the organization? Kim, you want to tackle that one?
Well, I'll start off, but I'm really looking forward to hearing Kim and Greg on this one.
All right, go.
'Cause I have to say I have a fairly coned down perspective, um, and Frank, just going back to the clinician, um, you know, over my career, I started practicing in 1990, and I was in a health center where we was all on paper,
Mhm.
and, um, uh, and I frequently didn't have the patient's chart when I was seeing the patient, and so I had, which is more like an emergency room doctor, right? Emergency department doctor, when they don't have any history on the patient. And the the quality of my decisions when all I had was the patient's memory of their own history was like, and the thing is, I didn't know the how poor the decisions were until over the subsequent 15 years, I got more and more. First, we got our own electronic health record data,
Mhm.
and then we became part of a health systems health record data. And at the end of that process, I had 100% of the data on this that occurred for this patient that occurred within the health system, and most of my patients got most of their health care within this health system. And so I always had the specialist note, whereas before,
Mhm.
maybe it had arrived in the mail, maybe it hadn't. So we've just come such a long way. What I see Tefka as is equalizing that across everybody. So that's the goal, is that no longer will clinicians ever have to make decisions in a vacuum of information. They will have all the information. Now, of course, Frank, that goes back to our first conversation about trust.
Trust, right?
But I'm hopeful that this is the last stage in many stages of making sure that any one of my families treated anywhere in the United States, and maybe eventually internationally, the clinicians taking care of them have the information they need. Now, let me just also add an additional framework element here, which is the difference between a push system and a pull system, um, from an incentive point of view. And that is, yes, Tefka allows me to pull in all of the information on my patient. But what if, for example, Tefka enabled an AI engine was giving me clinical decision support, and it automatically pulled in all the information so that it was making inferences. The AI LLM was making inferences on all of the information by design. That is very different and ups the ante for the use of Tefka to be not available, but always on. And that's a very different way to think about it, because
Mhm.
it wasn't designed an always on system. It was designed as a as needed system.
Mhm.
I have a feeling AI is going to push us even further on Tefka to make it basically always on.
Interesting. Dial tone.
Uh, so it's sort of interesting if you look back to the fire maturity model that we were speaking about earlier. You move from just API and interop up to the level of fire subscriptions and notifications and all that. So it's basically similar to what you're saying, Tim. It's like you really are getting to a point of using the data strategically and in a much more powerful way when you're talking about it being automated and inference is coming, as opposed to the moments when you go and search. Back to your original question, Frank, in terms of how do organizations, or when do we start to see organizations move from this being a checkbox, I need to be part of QHIN and do Tefka, when do we see it moving from that to like truly being leveraged in a strategic way? And I think it goes back to what I said in one of the earlier questions, which is you've got to start with why. And I think Tim just gave us the why, right? To really do effective patient care and the best care for the patient, the best like whole patient care, holistic patient care, you've really got to have access to all the data. It's not just about the single lab result or the lab results from today. It's seeing everything, including what support does the patient have at home? What are the social determinants of health? What are the other elements that are going to impact how the patient takes the care from you in this setting and actually is able to, go forward and be successful and, pick up their meds and do all those things. I think having the most data you can for that, it really helps you treat the patient as a person, right? So obviously having access to all the data is important. There's a question, I think, of what do you do when you get all the data? So I was recently in a focus group at a conference, Vive, prior to HIMSS. And I think it was with CHIME and it was with several CIOs and leaders from other hospital systems around the country. And a lot of them were using the national networks, not as much Tefka, some Tefka, but a lot using the national networks through Care Quality, Commonwealth, which also provides you access to the data for treatment. A lot of them were using them, but having a lot of strong pushback in some cases from their members, because the providers want the data. They want to see the data, but the second you see it, you're like, oh, wow, what am I going to do with all this data, right? And I don't think in most organizations they're saying, oh, well, now that we're giving you more data, we're going to give you more time with the patient. Tim, correct me if I'm wrong, but in fact, they're thinking the opposite, right? We're thinking the more technology we give you, you should be able to get to this more efficiently.
Ambient, for example.
Yeah, ambient technology, even different ways to present information. And so what we're hearing from a lot of our customers is, how are you going to help us make this data meaningful? And not just trusted, but meaningful and actionable. And so a lot of the work we've been doing we have a product as part of our suite that brokers access to the national exchanges, so through Commonwealth, eHealth Exchange, and that will obviously give you access to Tefka as well. But a lot of the work we're doing there is not just around making sure we're collecting all that data, but aggregating it and harmonizing it in a way where we're deduplicating, keeping the provenance, as Tim mentioned, as much as we can. But of course, the more hops the data comes back through, the more challenge there is with that. And we do our best there. But we're also looking at now, how can we apply more intelligence to that? How can we apply some of the AI capabilities that we have in our standard clinical viewer product and let the user run prompts that are specialty specific or care specific to really pull the right data out of that chart. Once you start to get data, I mean, me personally, I've lived in Boston, New York. I'm Canadian. I've lived in Boston, New York, San Diego, Australia, back to Boston, back to New York. On any given day, who knows what state I'm in, right? You pull my record, you're going to get data from a few different places, right? And none of it's going to tell you that I love New Kids on the Block, but you've got to look through a whole pile of data, and a lot of that's going to be in notes. The further you go back, it's going to be piles and piles of notes. So I think it's really important to really help people make this strategic. It's going to be about, how do we make that data meaningful and actionable without accidentally cutting out the important stuff. And that's always going to be an important line, but I think it's going to be really important to actually move this forward. The other thing with TEFCA, which I think is really interesting, and we're starting to see some traction here, though less than we expected, with Commonwealth and care quality and all that, providers get good access to treatment data. What they do with that data and how they roll it out, of course, is part of this question. But there's other use cases that you are now going to be empowered through TEFCA, and that's access to the data for payment purposes, right? For provider payer exchange, access to the data through the individual access services for individual mandate, where me as a consumer of healthcare could say, hey, I want to get access to my record, and or I want to give a life insurance company access to my record, or another type of organization access to my record, because I'm doing business with them in some way, or I'm interacting with them in some way. That's where I think TEFCA is going to get pretty interesting, and seeing how organizations are looking at how they approach empowering that type of exchange, I think is going to be really interesting in the coming months and year or so. So we're seeing a lot of movement towards that, both in the vendor space and the organization space, of figuring out how to do that well, how to do that with proper compliance and governance and trust, but also honoring the interests of the individual patient and consumer in all of this as well. So I think there's a lot of interesting stuff.
I agree.
That is opening up.
I want to add to the next question the facet that there are very small healthcare organizations that have to do these things as well, as compared to Mass General or Mayo. So I'm sort of interested in that, and I'm going to lead that into the next question. And this will give you an opportunity, Greg, to pick a fight with our survey respondents. That 80% of those organizations, 80% say their community partners simply lack the interoperability capability to keep pace, making partner readiness the single biggest barrier to full exchange depth in the data set. This could be for TEFCA, it could be for other things. I'm just curious how InterSystems responds to 80% of the people feeling that their partners might not be on the same maturity model or let's call it accelerated model that the market represents right now. How would you respond to that? And I want to go back to that with, we have lower maturity healthcare organizations start out with, and then we have people that are in rural areas that have a man and a cow that are running the IT department out there, and that what do I do? So what do you think about the natural suspicion of organizations thinking that their community partners aren't keeping pace? Fact or fallacy?
So I'm not going to argue with that survey result, because I think that accurately reflects how folks feel. And I'm also not surprised that that's the result, especially as we continue to expand the circle of partners that we want to connect with, right? So now all of a sudden, I also want to pull in, say, dental information, or I need to know somebody's housing status, so I want to connect to community partners. These are all folks who have their own purpose-built applications that are not EHRs. And their organizations, there's no reason for them to implement an EHR. It doesn't match their business model and what they need. So I think that the result is probably accurate, and it's going to continue to be a challenge in our ecosystem going forward. I think the rural health transformation project out of HHS is also a big recognition of this. I mean, one of the HIEs that we work with is Big Sky Care Connect in Montana, and having a chat with them about rural health and their challenges. They point out, as you said, one man and a cow type operations. A lot of the small community physicians or independent physicians in their state are using an EHR system that was built around, say, an access database, or built for them 14 years ago. It still works. It delivers what they need for them to provide care for their patient. But as we think about connecting those providers into the larger network, it's going to be a challenge. So I think that it really comes down to a lot of factors, though. I think, part of it is, as Kim mentioned, we, as a company, we have certain things in our platform that can support that. And I'll let Kim speak to that in a second. But I think what we really need to look at is what data do we need? And is that data, does it exist in the ecosystem today? And then what are our standards that we're using? One of the things I do here at InterSystems is work, or more accurately, listen in on the Gravity project with HL7, which is really focused around trying to develop fire standards for SDOH data exchange. And one of the big challenges we have, and coming out of the human services space, I will say, even within the same department and same programs under federal agencies, we have wildly different definitions of what our data is. And it makes sense, that data standards are based upon the program needs. But as we're trying to weave all of that together, we really do need to put a lot of focus on coming up with the standards so that we can then have the FHIR APIs and start exchanging that data and do it in a way that builds confidence and builds trust.
Perfect. Great. I want to be sensitive to time. I have a, excuse me. We have a question from the studio audience. And I always love this question. I try to ask it myself as a former long-term patient. Where does all this stuff tie into patient satisfaction and happiness? First of all, I'm going to tie that into as part of the answer to the next question. The research shows that population health analytics are nearly universal, but only leading organizations consistently connect those insights to automated work lists, care gap alerts, blah, 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 everything else, clinical tasks. And I would argue, I chair a patient family advisory council at Spalding in Boston, and I would argue that connecting to patients and families is another part of it. This is sort of the mysterious part out there. This is all about patients, but how do they actually feel it? So I'm wondering how, from what you're saying with population health data, we saw it obviously during 2020 with COVID, that was the prime time of population health. Is we could all finally figure out what it was when you say population health. This is it. How is that dissemination of data from population health statistics and everything else that we have, Tim, playing into it? And your customer, if you will, people hate when you say that, is the patient. So where do you feel it's touching the patient?
So what is, I mean, the past decade has been characterized, from my perspective, with some absolutely brilliant, well-studied examples of population health, where you have two sets of data. One is the aggregated data sets where you're looking for patterns, and then you've got that's de-identified, and then the identified data set, which is where at the level of the individual, where the gaps are. And then there's two different consumers of that information. At the aggregated level, it's the leadership, population health, value-based care leadership, and at the individual patient identified, it's the care manager, population health manager, whatever you call them, working with patients to close those gaps. So that's the ecosystem that was developed in response to value-based care and population health. But Frank, I started with the word sort of pilots and early work. It never went anywhere. And it never went anywhere because no one in the healthcare system is actually paid to do what you are describing. And value-based care attempts to get at it by, if you deliver proactive care and you can lower your cost trend, you get rewarded. It's a bit of a hurdle. It's a lot of work, and it's fairly short gains on the back end of that. And so we have the infrastructure, we've got plenty of evidence that it works, we've got a lot of people who want to do it, but we have not figured out a payment system in this country that rewards it sufficiently for people to go after it. Of course, the example that everyone uses is Kaiser Permanente, because they are both they're the payvider, they're the archetypal payvider. They have a direct incentive, financial incentives to do this work, but and others have some incentive. I would just say that it hasn't really taken off because the incentive is quite small.
Any additions there, Kim or Greg?
I'll just say, like, I think it's the Bill Spooner question. I think it's a great question. I would say that I don't necessarily want to say that FHIR or AI or TEFCA, just as standards or as technology like constructs, are what gives the value and the improved access and quality. When they're used to solve the right problems, they do, right? So it's all about the why. It's all about what is the thing that will, make access to care better, make the clinician's job easier, from the perspective of giving them the things they need to treat the patient correctly. When all of that, when you're doing the right things to solve that, FHIR, TEFCA, AI can give you some of the underpinnings to let you solve those problems. But you could have an organization that uses FHIR and has 17 different AI projects running in tandem, and it's on TEFCA, and still not be solving those things and providing improved access. But if you have the right goals and the right outcomes you're shooting for, that all of those can actually help you drive that. So I've definitely seen throughout our customer space, as well as when I was on the customer side, I've definitely seen us be able to use FHIR and early elements of AI to really, give improvements there with like real outcomes and real metrics around it. And I think that's important, making sure you got your metrics and making sure you're using the right things for the right reason and not just technology for technology's sake. So I think it's very possible.
Great addition.
Can I have one quick comment? Just very quickly, I want to really underscore what Kim just said, because I look back when I was building value-based care programs and population health programs in 2010, 11, and 12, and I would have loved some of the technology tools that are available today. I had everything was manual. Everything was difficult to do. Much easier now. And that's good. That's lowering the bar of entry for doing this kind of work.
Great addition. Great addition. We're sensitive to time here. I think this will be our closing question, and I think it's probably one of the most fascinating. And I've done conferences on this, so it could take longer than the 5 minutes we have left. But it goes back to who do you have in the room when you start developing a data literacy program, especially digital data literacy, which it takes on generative and all the other things. I mean, it's hard enough with now. It's not even Dr. Google; it's Dr. Claude that people are going to, and we've got the whole problem of shadow AI, which is it's running rampant. So there's just distributed literacy challenge that we have that are happening in nooks and crannies within organizations. Greg, if you were putting people in the room, who would you have in the room if you were doing your launch data literacy program in the organization? How many pizzas would you have to buy to feed that number of people in the room? What are your findings on deploying a credible data literacy program in a world where data literacy is momental? It's just what my last Claude feed had.
Yeah, I mean, I think the answer of how many pizzas, how many you got. I would want to bring in, for true data literacy, you almost have to bring in everybody who's going to be working with that data and provide them something. Now, obviously, you can't have 500 or 5,000 or 50,000 people sitting in on your data governance
Right.
council and designing those things, right? So what you do want to make sure is you have representation from sort of all the strata and all of the different spheres, informing the policies that you're setting, and then being able to push those out to your team broadly, right? In some sort of educational process, whether that's here's your monthly training, and hopefully that's fun and fast, because we all know that training on data literacy is job 37 on your top 5 to-do list for most of these folks. And so, you don't want to make it too burdensome for them, but it is really important to understand this is where the data is coming from. This is what it means. This is how we're going to be using it. So this is why you can trust this or why you shouldn't trust this. And by the way, this is where your data goes. So, I've been at several conferences recently where folks talk about how incredible it is that folks are very concerned about not sharing their data, but then they'll take their entire health record and upload it into a publicly available AI product, and feed it all in. And yes, they're doing that out of wanting to empower themselves, but and it's understandable. And look, if I want to do that with my data, that's my choice. That's fine. But as an organization, folks should know, yes, this is the tool I can trust. This is why I shouldn't be using these other tools, and this is why. So I think data literacy has to be everybody's job throughout the entire organization. It can't just be, it's IT's responsibility to make sure. And by the way, IT needs to be the only person involved in deciding what we're trained on and how we're trained and how it's explained, right? The terminology that I'm using to explain something. I'm not a technologist, right? But as you sit with the technologist and having sat in a lot of those meetings, are they explaining things in a way that makes sense to the end user community? So
can I have one like really quick sentence on that? I think it's got to start with the people who do the work. So not the people who think about the work or talk about the work, but the people who do the work. When I was on the health system side, and I still try to get as close to the real work as I can, no amount of meetings could replace me, getting up at 6 a.m. and joining a surgeon when he did his morning rounds. Like, you see it and you feel it and you hear the words that are used, you understand the real problems at a much different level. So with data literacy or any of the things we've talked about, it's got to start by truly understanding the workflows of the people who are doing the work now and what they truly need, not what you want to talk about in a meeting or what they need, but what they truly need to deliver the care differently or to understand the problem differently or to talk about the problem differently. And I think data literacy is in the same category. It's got to be rooted in really understanding what the real work looks like.
Totally agree. And I think most of this, as we're seeing, is bringing in the not so typical suspects into these meetings. I mean, obviously, HR becomes more and more involved in this because digital literacy is part of the survival of the organization, of getting valid information or not. So that's a great answer to the question. And we'll be doing more on that generative data literacy aspect of the business as well. Unfortunately, we're landing this plane on time, or fortunately, I guess it is. I'd like to keep on talking, but I just want to see if there's any last minute closing questions you have for each other. Or if not, I want to give my sincere thanks to InterSystems for being a supporter of the Digital Health Most Wired survey. I would encourage you to go to see the results. We have a lot of findings that we have in terms of segment reports, of which this is one. And I think you'll find the findings for next year's report even more interesting as we modernize this to try to keep pace with what's going on in the marketplace. So to our panelists, thank you so much for being with us today. For our audience, thank you for taking out the time. And for InterSystems sponsorship, we greatly appreciate it. Thank you again, everyone.